Hello, and welcome to my case study on pediatric cardiology. So, a 1-week-old baby is brought to the clinic with complaints by the parents that the baby is not feeding well, having difficulty feeding, and every once in a while looks a little bluish. So, the RN examines the newborn and discovers when the nurse holds the baby that the baby has what we call a hypercyanotic spell or a TET spell. Baby gets cyanotic around the lips, has difficulty breathing, acts agitated, and is crying. Oxygen saturation at that time is 80%. When the RN listens to the heart, a loud, harsh murmur is heard on the left lower sternal border. When the lungs are auscultated, they are clear to auscultation. We're paying attention to see if there's any crackles because the RN is already kind of thinking that this baby may have a congenital heart defect based on the symptoms that she has seen, the signs that she has seen. Also noting the respiratory rate is 55 breaths per minute, which is slightly tachypnic. So the baby is admitted to the hospital after the provider was notified and tests are done. An echocardiogram is done, which is an ultrasound of the heart. An ECG is done, chest x-ray, and a complete blood count. So what are the findings? So the echocardiogram does show signs of tetralogy of Fallot. Right ventricular hypertrophy, so the right side of the heart is enlarged. Decreased pulmonary blood flow, so it's harder for blood to get from the right side of the heart to the lungs. And decreased size of the pulmonary artery. Again, that is the artery that is taking the deoxygenated blood from the right side of the heart to the lungs. The ECG also shows right ventricular hypertrophy, and the CBC shows increased red blood cells. We call this polycythemia. So what happens with polycythemia, there is a decreased amount of oxygenated blood. The kidneys sense this, so they try and increase the red blood cells by increasing the amount of erythropoietin, which tells the bone marrow to make more red blood cells. What could happen with this is there can be too much blood flow and too viscous of blood, which can put further pressure on the heart. A diagnosis of tetralogy of Fallot is made. So in tetralogy of Fallot, there are 4 defects. And this is a classic NCLEX question. So pens up, no tetralogy of Fallot. And some nursing students and nurses get confused with the different defects. But they are overriding aorta, which is an enlargement of the aortic valve, ventricular septal defect, so there's an opening in the septum between ventricles, pulmonary stenosis, which is a narrowing of the pulmonary valve and that outflow tract, that blood that's going to the lungs, and right ventricular hypertrophy, so the right side of the heart is enlarged. If you look at it in this diagram, which is also in your text, it's easier to talk through these different defects. If you start by thinking of the overriding aorta, and that is, these defects are congenital, so the baby is born with these. So when the baby's heart is being formed, this first overriding aorta, usually the aorta is just on the left ventricle, right? Because that pushes the blood out to the body after it's been oxygenated. Actually, let's back up and go through the normal flow of the heart, of the blood. The blood normally comes from the inferior and superior vena cava, goes to the right side of the heart, the right atrium, down through to the right ventricle, and then goes up to the lungs through the pulmonary artery. And remember, artery means going away from the heart. So some people think artery oxygenated. Don't think that. Think artery away. So the pulmonary artery sends the deoxygenated blood normally, and we're not talking about tetralogy of flow, away through the lungs, gets oxygenated, comes back through these pulmonary veins from the lungs to the left atrium, to the left ventricle, out the aorta to the body as oxygenated blood. So back to tetralogy of Fallot, when you have when the baby's heart is being formed in utero, the aorta should be coming off of this left ventricle, but the baby has this overriding aorta. So it is taking up too much space in the heart, and there's only so much space in the heart. So it's taking up too much space, and it prevents the ventricle septum, that wall that goes between the two ventricles, that prevents that septum from being formed. So we now have this overriding aorta, which is causing the VSD, the ventricular septal defect, and that's further squeezing out the amount of space that is in the area of the heart. So you have this pulmonary stenosis, this tightening of the pulmonary artery, which puts pressure, and it's harder then for the blood to go to the lungs. And then it's putting more work on this right ventricle, so it's causing right ventricular hypertrophy. All of this is causing a decreased pulmonary blood flow. So pens up, so decreased pulmonary blood flow because blood cannot get to the lungs as easily. So when you have a decreased amount of blood going to the lungs, you're going to have a decreased amount of oxygenated blood. So you have cyanosis. So what is the treatment for tetralogy of Fallot? Well, babies will put themselves, sometimes toddlers, children, if they still have tetralogy of Fallot, will put themselves in this tet position. And the tet position is a squatting position. And what happens with this is the knees are brought to the chest, the child squats down, or even the nurse can put an infant into this tet position. What happens is that it causes more pressure to go up to the heart, so the more blood flow can go to the lungs. It happens because there's a pulmonary spasm, which decreases the amount of blood flow that's going to the lungs initially. And an older child is able to recognize this, and will have cyanosis, and they naturally will know to get themselves in this position, they will feel better. Babies will have surgery to correct tetralogy of Fallot. So what are some other important points on how to manage tetralogy of Fallot? Number one, we really have to support the parents and caregivers. Having a newborn or a child with a congenital heart defect, such as tetralogy of Fallot, is obviously very stressful. There's 4 different defects, so multiple surgeries may need to be done. We do want to encourage a healthy growth and development of every child. Every child needs to play. So we want to encourage parents, although they need to be cautious with their children, they do need to foster that normal growth and development and socialization with other children. Sometimes they get so worried that they're going to get sick or get out of breath or have a tet spell that they really restrict their playing. And this will compromise the child's growth and development. So we really need to work with the parents and support them for this. We do also need to encourage the child to have rest periods. Whether the child is in the hospital, if it's a newborn, we need to decrease the amount of interaction, because remember, when your heart is under stress, it's going to beat harder and it's going to cause an increase of oxygen requirements. And it's almost like running a race if you think about it. When you are running a race, your heart starts beating faster and you need more oxygen, so you start breathing faster. So with children that have heart defects, we need to try and help them have increased rest periods. Also, to just review some of the heart defects, disorders that have decreased pulmonary flow are tetralogy of flow, as we just discussed, and tricuspid atresia. Other disorders that have increased pulmonary flow are atrial septal defect, or ASD, ventricle septal defect, or VSD, which is just an opening between either the atria or the ventricles, atrial septal defect or ventricular septal defect, just an opening in that septum. And remember that there is a pressure in the heart. And normally the pressure is higher on the left side of the heart. And if there is a opening, then the pressure will equalize and there'll be increased pulmonary flow because that pressure will now go from the left to the right, and then that right side will then put more blood flow up into the lungs. The other defect that increases pulmonary flow is a PDA, or patent ductus arteriosus. If you think of a patent ductus arteriosus, first, patent means open, and ductus, think of duct, and arteriosus. So this is an opening in the area in between the aorta and the pulmonary artery. Babies that are in utero will have this PDA, and then it should close very soon after birth. Sometimes it doesn't close, and this stays open, and we call that the PDA, patent ductus arteriosus. Now this causes an increased pulmonary flow. This blood, if you think about it here, remember the right side of the heart is deoxygenated blood, which is going to the lungs, and the left side of the heart is oxygenated blood, which should be going to the body. When you have a PDA, or patent ductus arteriosus, this oxygenated blood from the aorta is mixing with the pulmonary artery and going back to the lungs. So you have oxygenated blood from the left side that is going through the aorta and going right back to the lungs instead of going to the body. So we have too much blood flow going to the lungs. This can lead to increased pulmonary congestion, wet lungs, coughing, pneumonia. So we need to, most of the time, fix this patent ductus arteriosus. If it doesn't close, most of the time it'll close on its own, but if it doesn't close, then it needs to get surgically repaired. Thank you.